Okay, so we are here to make a summary of yesterday's webinar and to clarify what has not yet been thoroughly understood. Therefore, I'm gonna tell you what I understood, and after each concept, you stop me and I stop myself, and you correct me. So, I see it like this. The basic principle of osteopathy is that you have the body as a wondrous mechanism, which is composed of different systems, and they cannot be addressed separately. So this is the foundation of osteopathy. Is it correct?
It's correct, but let me just add this. There are people in osteopathy who look at the systems, who look at it that way. From the founder, he considered the body as a unit. So you can look at a body system, but you have to realize it's part of a greater unit. That's his philosophy. That's the founder's philosophy. When it went from the founder to John Martin Littlejohn to other people, it's gone in all kinds of different directions.
Okay, so you resonate with the founder's philosophy. That's what you are telling me. Okay.
Yes.
Okay. And what an osteopath would do would firstly understand very well how the body functions, and then would try to put things into places so that everything would go to its optimal function again. Is this the way it works?
It's one way. These answers are going to be complex in the sense that there isn't one way osteopathy is done. There are people who just apply things very locally.
No, we are referring to you.
Okay. Okay, I'm giving you the broader picture and I'll tell you me. The way I work is you tell me what the problem is. I have a headache. My neck hurts. My back hurts. I write it down. That's why you came to me. Then I put you on the table and I look for what feels wrong to me, which could be anywhere. I will also do things locally to the area you're complaining of. I'm sure I'll find things locally. If you say I have a headache, I'm sure I'm going to find things in your neck and your head. Anyone will find it. But I look for other key lesions, which is an old osteopathic concept. Key lesion may not be something the patient is even talking about or aware of. It's something the osteopath may find.
That's lovely. Okay. An osteopath will can address all types of diseases. So just like I'm not talking about surgery here, but it's not limitative. It has a very broad spectrum of diseases that he can address. Is that right?
Correct.
Okay.
It does. Hold on. It doesn't mean that I have the cure for everything.
No.
But I have an approach to everything.
Exactly.
That includes things like cancer. Not a cure for cancer, but cancer is not only your life. Your life is cancer with pain, with not sleeping, with digestion problems, and many aspects of it can be improved, the quality of your life.
Okay. You also told me that, so let's say from the types of diseases that could be fixed, that there is a success ratio. Actually, I heard in another video. So your success ratio is 75%, you said?
Yeah, let me explain what 75% means.
Okay.
75% means 3 out of 4 people that come to me that are complaining of whatever they're complaining of, anything and everything. 3 out of 4, I'm either able to make it go away or make a difference so it was reasonable to come to me in the first place. 1 out of 4, I do everything I know how to do. I make no difference whatsoever. And it doesn't matter whether it's an easy problem or a hard problem. Sometimes I get an easy problem. Wow, this should be simple. I do everything, nothing. Then I get these impossible things that I will show you on video. I think, no way can I help this person. And some part of their life feels better or a lot better. That's what I mean by 75%.
The osteopathy is a truly holistic approach and has those three principles with the body as a unit. We talked about that earlier, with the structure and function, correlation between structure and function, and the capacity of self-healing of the body, right?
Correct.
Okay. You try to stay away of anything, any limiting directions that other osteopaths took, right? The clubs you were talking.
I'm not sure what your question is.
You said it's not a question; it's a conclusion I draw after watching the webinar, and you said that different osteopaths took different directions and like
Yes.
clubs, and you have lended your ear to them, but then didn't stick to any of these directions, just took whatever you felt it worked for you and applied it in your approach.
Correct. Let me elaborate on that for a moment. What works for me might not work for you, or it might not be a style that appeals to you. Within osteopathy, it's like an artist with a palette of many different colors. We don't have to use the same colors. Some colors are going to be more appealing to you. Some styles will not be appealing to you. So I listened to my mentors. I listened to what they said. I tried many things. Some things appealed to me right away, like cranial. Right away, I liked cranial. I said, this is me. When I first did visceral, I said, this is not me. This will never be me. And then later on, it became me. So you go through a lot of changing through the education, but you should be exposed to all the colors. You shouldn't be edited out by your teachers, the colors. I don't want to be only a cranial osteopath. I don't want to be only a myofascial therapist. I want to be exposed to what there is, and then I will choose.
Okay, so your program will show all the colors and
My program will show all the major colors. Because every month someone comes up with a new color. Sometimes it's not actually a new color. It's the same as an old color.
Nuance. Okay. 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 About measuring results. So the conclusion from the webinar was that although from its beginning, people have tried to document the results they got, because it's a combination between art and science. You will never have something like a double-blind study.
It's difficult to do that. I won't say it can't ever be done. We could compare. The difficulty is this, and I'm a clinician, I'm not a researcher. The difficulty is this. When I was a resident, they were starting a headache study they wanted to do, and they wanted to study a large number of people over many years. That's the way you make a study. To make a conclusion, you need a lot of people, you need a lot of time. Okay? You can't say, I treated 8 people for back pain and they got better. That's not a study. It may be true, it may be absolutely true, but it's not a study. When drug companies study things, they give 10,000 people pills. That's how you get reasonable numbers. So I was at the college, they wanted to do a headache study, and they wanted to compare different osteopathic modalities for treating a headache. One will do cracking the neck. One will do counterstrain technique. One will do cranial technique. One will do something else. One will do fake technique. And they wanted me to get involved in the study when I was a resident. And I said, how are you going to control for the operator?
Mm-hmm.
And they said, well, we're going to do fake technique. I said, see, I don't believe, perhaps from you, if you put your hands on somebody and pretend to do something, I think it could still be therapeutic from the right person. Energetically, I don't know that we can discount it and say it's fake. And I don't know how I compare neck cracking to cranial to visceral, because it depends who is cracking the neck, who is doing cranial, who is doing visceral. So I just don't know the method, how to get a reasonable study on that, because we're not machines. We're doing something scientific, but the way it's applied is art. And we absolutely talk about art in medicine. We don't talk about the doctor who prescribes pills. We don't say she's an artist. The doctor who does surgery, we say she's an artist. We absolutely say it. The people I'm talking to today are dental surgeons. They absolutely look at it as an art. They study medicine, but they're artists, and they absolutely identify with it. So to study things, I don't know how to do it. I personally have no interest in it. I have an interest in applying the art as I understand it. And I will just go a little bit further. One of the problems in my profession is people just think it's about techniques. Techniques, look at videos, look at Google, YouTube, watch people doing whatever techniques you want. You'll get plenty of techniques. It's how you apply the technique. Every painter can play with colors, but there was a few masters who knew how to really paint. It's the same in the touch profession. It's not a set of techniques. It's an understanding of principle. If you understand that structure and function have a relationship, you approach the body differently than just saying, you have a frozen shoulder, so we should look at rotator cuff muscles. That's a very low way to think. You have to see the relationship of those muscles to the whole organism, to the shoulder girdle, to the thoracic outlet. If you can understand that, it changes the way you paint. We're not a set of techniques. Techniques are okay. People will get better from you doing technique. They will. But they'll get much better from someone who really understands the body.
Okay. I think you covered everything I jotted down because you elaborated on my first questions. So this is it uh, as for the summary.
Okay.
For
I would
today.
like to show you something then if you're done with questions.
Yes.
Okay. So I'm going to show you a video. I didn't used to take videos of kids, disabled kids. When I'm working, I do a lot of charity things for kids, and I didn't like to take pictures of them because I feel bad enough for the parents, you know, they have a disabled kid. And then after a while, I said, you know, can I take a video? I want to use it for education. And some of the parents said yes. So I want to show you a video of a child I treated in 2005. And this is what you're going to see is basic cranial, basic myofascial, basic visceral, except for the intraoral. You'll see me put my finger in the kid's mouth. My point is the great things, if I've done something great for somebody, it's been with basic technique. It is a wrong direction to think that there must be more secret ways to push and pull. That's not what osteopathy is. It's the artistic way to push and pull, to merge with the tissues. So I want to show you a child who was, I'll tell you the story first, and then I'll show the video at 7 minutes. And then there's one other thing I want to show you. This child was brought to me. He was a hypotonic baby, which means he didn't move. He didn't do anything. He could eat, but he didn't lift his neck, didn't sit up, nothing. 2.5 years old. I was teaching in Hong Kong. My friend said, can you treat this baby? My answer is always yes, after class. So I used to be in Hong Kong for 3 days. I would have seen him on a Friday and a Sunday. I tried to treat him on Friday, and he immediately started trying to pick his head up. He couldn't because he's never done it before, so the muscles wouldn't allow it. So in this video, what you will see is 1 year later. This was in 2005. At that time, I was going to Hong Kong every 3 months. So I would have treated him 8 times over a year. In between, my friends were working with him with cranial and such, so forth. So at age 2.5, the doctors had already thrown this boy away. He'll never do anything. That's the story. Very sorry. No hope for your son. So I'm going to narrate the video and I'm going to show it to you now. I'm just going to change the, no, you don't have to do anything to your screen. Hold on. Where am I going here? Here's where I'm going. Share. Okay, it says here his name is Ji-san. That's not really his name. The Chinese have cute names like Ji-san, Ching Ching, Lum Lum. I know a lot of kids like this, so it's not his real name. So now you can't really see from this because I didn't take pictures. This was the mom's picture. That lump in his head is called a trigonocephaly.
I cannot see anything.
Oh, you don't see anything?
No, no, I saw window with files.
Hold on, hold the phone. I'm going to share screen. Desktop. Oh, I know what I did wrong. Do you see something now?
Yes, the previous images show that.
Okay, let me back it up. I know what I did wrong. I should know this technology. All right, let me back this up. Oh, come on now. Back up, back up.
Maybe it's with these arrows, like
Yeah. There we go. Okay, there we go. Okay, so I'm going to narrate this and then you can add whatever captions later. I didn't have pictures of him from before, and I asked the parents after I treated him, hey, do you have any pictures of him? So these are photos they had taken. This lump on his head is from his metopic suture. The metopic suture was restricted. He came to me as a floppy baby. He was doing nothing except eating. You're going to see this treatment. This is 1 year later. I saw him every 3 months. You're going to see a kid kicking and moving around. He wasn't doing any of that. This is a complete treatment, whole body. It's 7 minutes. So I'm doing a sacral release with 2 fingers. You'll see how quick I move. I'm not staying here waiting for rhythm. I'm not waiting for the tide. I'm doing my releases and moving on. There's a diaphragm release, pelvic diaphragm release. Done. Abdominal diaphragm, I'm doing it with 2 fingers actually. My index finger and my thumb. Thoracic outlet, diaphragm. This is how quickly it can be done. Doing an OA release. Now you can see here, that flattened right away because the suture was not actually closed, it was just restricted. OA release done. Frontal lift. This moving his hands, he did none of this when I first met him. Nothing. Bridle compression and lift. Sphenoid diagnosis, compression and lift. Or compression, decompression. Done. None of this movement he did when we first met. Temporal release. Molding technique. This is volar maxilla palatine. I'm addressing very quickly because he's biting me fairly hard. Now, his head is flat.
No.
It's flat because he laid on it for 2 years without moving.
Cái đó mình chỉ là phải có mắt trên này. Very good. Very good. Có được. Cái bên tay.
Doctor said he would do nothing ever.
Okay.
He's not normal here, but he's not the same baby he was. He's not a hypotonic baby anymore. This was in 2005. I didn't have follow-up after this. At this time, we weren't sure if he was blind. I was trying to get him to track with my finger. I couldn't get him to do it. That's basic technique done well. I'm not saying done well, patting myself on the back. I have plenty of cases where nothing has happened for me. I haven't gotten the result people want. But it's not a question of a secret technique. It's a question of becoming one with that other person and finding out where their restriction is. I want to show you another video that's not as happy as the one you just watched. And he was the child of a friend. I don't know if you know the term SIDS, sudden infant death syndrome.
Yes, I know.
Okay, a baby rolls over on its stomach and they suffocate. So I want to show you one more video, and then I want to show you a quick PowerPoint that I think will help people to understand what I'm talking about. Oops, sorry about that. Let me just make that go away. Okay, sorry about that. I saw I have my mail program open. Let me close it. Okay. So I want to show you another video. This child was the son of some people close to a very close friend of mine. He was a normal baby. At 1 month, something happened. He rolled over in the crib. He ended up having to be resuscitated. So he was a SIDS baby that survived. So what you're going to see is a completely, totally disabled child. And in this video, he's 5 years old. It's also in 2005. The complaint was he was starting to desaturate at night. He's on a nasal cannula for oxygen at 0.75 liters. And he was starting to spike down into the 60s. That's not compatible with life. Below 80, we have to put a tracheotomy there and you're on a breathing machine for the rest of your life. So my friend said what people always say to me, can you do something? I always have the same answer. I don't know. Let's try. I treated him twice. It would have been a Friday and a Sunday for the time that I'm in Hong Kong. The desaturation stopped, never desaturated again. But this is not a normal baby. It's very sad to watch. What I want you to see is basic cranial. Again, I get this question all around the world about, in advanced cranial, we do other techniques, and there'll be things that'll probably be new for a lot of people that are not in the osteopathic world. And there's other ways to learn. But I can't stress enough, if you do basics really well, that's what people need from you. They need a skillful hand at basic technique. They don't need some magical thing coming from outer space. This is what people think. So I'm going to narrate this video. And then I have one other thing I'd like to show you. So let me hopefully I don't mess this up again. So let me share screen. Okay, desktop. Whoops. Okay, I get it. Wait a minute. Okay, again, this is not his real name. It's just like a cute name, Jun Jun. And he's 5 years old. I don't think he weighs maybe 15 kg because he doesn't eat right. He's on a nasal cannula. Wait a minute, where's the video? There we go. So this is Jun Jun. At age 5, he's got a head about the size of a softball, completely microcephalic, because he doesn't chew right. The face doesn't develop correctly, because your face develops as you chew.
I'm sorry, I think I have a problem with my computer.
Okay, hold on.
Okay,
I'll stop it.
I can see now.
Okay, let me just start it again. share screen, and then you can edit out as you like. Okay, hold on a second here. There we go. Okay, so this boy was a SIDS baby. He was a normal baby. Imagine that, being normal at 1 month, month and a half. He must have rolled over during the night, and they had to resuscitate him, which means he was dead. This is at age 5. Can you see the video?
Yes, I can.
Okay. At age 5, my friend said he's starting to desaturate into the 60s. They're calling him cerebral palsy, but it's just a diagnosis because they don't know what else to call him. He can do nothing. He cannot sit up. He cannot roll over. He's on a feeding tube. He's on a nasal cannula for oxygen. This is his life. When he was desaturating into 60s, the next step is to get a tracheotomy and be on a breathing machine. They said, can you help him? I don't know. Let's try. I treated him twice during that weekend, and the desaturations never returned. He's not at all a normal baby. His life is totally disabled, and he's in a lot of pain. I'm starting with a sacral release and a diaphragm release. Junjun weighs like a piece of paper. Everything is fragile on him. You'll see him periodically have apneic episodes where he stops breathing. The tape clipped out. I went through the other diaphragms and I'm up to the thoracic outlet. I'm working on his hyoid. He stops breathing. Now, this is OA release. And if you look, you'll see how high up his arch is. I'll talk about that later. You see his face is round. It's not developed because he doesn't chew. When I do an OA release to you, you like it. When I do it to him, it's painful because his tissue is so tight. I don't want to hurt him, but I need to help him. Frontal lift. Parietal compression lift, hard to see. Sphenoid evaluation and treatment. And temporal for him will be very, very painful. That high arch has been because his arch vaults cephalad because he can't make an airway. So I'm doing again vomer maxillopalatine very quickly. It's hard to watch, I know. There's certain things I couldn't do in medicine. I don't have the personality for it. I couldn't treat burn victims. I think I would go home and cry every night. I wouldn't be able to get it out of my head. And things like this, which is really tearful, his whole life is nothing but pain. I had an interesting experience. I'll choose the word interesting in New York. I teach in different places. People have different beliefs. They look at life differently. I think all life is valuable, my own opinion. I don't ask anyone to share my opinion. I was in New York doing a big class, and I showed this video. To me, it's inspirational. It doesn't scare me. It doesn't make me feel bad. I made a good change in his life, and I'm willing to try. I'm happy about it. His life is terrible, but I was able to help a little bit. And one of the people in the class in New York said they had a question. And there's like, I don't know, 25, 30 people. I said, what's your question? She said, I made a mistake. I shouldn't have treated that baby because I extended his life. I should let him die. She said she found my video offensive. Now, I'm teaching seminars for a living. And I'm trying to think of how I answer this person because I'm not on the same page with her at all. And I said, well, the parents asked me, can you do something to help our child? I felt I could, so I did. I said, if you really feel the way you feel, you shouldn't be touching that child. That was a satisfactory answer for her, actually. Kind of got me out of a difficult situation to give an answer without lying about how I feel. No, you shouldn't be touching it. If that bothers you, no, you shouldn't be. You're either in helping them all the way or step away. Let someone else do it. So I've done a lot of charity for a lot of years. And it's funny, as I said, there's certain things I don't have the mentality for that would frighten me, like burn victims. Things like this, they don't. If I can make a difference, no one else behind me has any great idea. So I want to show you just some quick pictures from something I use in the advanced. I'll show you some pictures from around the world, some cases. My friends and I either go by myself or I get a team of people. I say, who wants to come with me? And we just treat an endless sea of kids. They come out from the woodworks. So I want to show you some typical kids we've treated. I'm going to hit the share screen again here, and they're just photos. So let me end this. How do I end this? How do I do that? All right. I should learn how to use my computer better. Hold on. Let me stop the share. Let me do it this way. Share screen. Tell me in a second whether or not you see a PowerPoint. Do you see a PowerPoint?
No, I don't.
Okay, hold on. Hold on. Stop share. All right, let me figure out something here. All right, I'm going to stop that. Now, I'm going to start this. Now, hold on, I'm getting there. Wait a minute. Okay, share screen. Okay, do you see a PowerPoint now?
A second.
Hold on. Do you see a PowerPoint?
Yes, I
Okay.
do.
Okay, I'm not going to go through this whole lecture, but there's some pictures I want to show you. Cranial synostosis is what happens when the sutures actually fuse together. In Jisan, it was not actually fused as metopic suture. It was just tight because I was able to change the shape of it. Synostosis, you're not able to change the shape. You can't change it, but you can get other sutures to be a little more pliable. So I want to show you some kids that we treated overseas. I don't have a lot of follow-up because we come into town, we work for a week, and then we're gone. Sometimes I've gotten follow-up from some of the parents or some of the hosts. Here's a baby I treated in Oman, 3 weeks old, cardiothoracic open heart surgery. She's got a shunt in her head. What's wrong with her? We get very poor history from the parents. The kid's suffering in every way imaginable. Can you do something for our daughter? I'm doing an OA release with 2 fingers. What will I do? First rule is do no harm. This is a colleague of mine, Abdullah Al-Mahaya. He was also with me in Oman. This is a scaphocephaly. Actually, the sagittal suture is completely closed, and you can see how thin his head is, like a pancake. All of these kids are off missing their developmental milestones. And many of them, we did get some feedback from the parents that they started with more coordination, better walking, and so forth. This is another scaphocephaly I treated. It's hard even to see how thin his head is. And you can see how much he loves my treatment. He hates it. This is the typical face of most kids when I'm treating them. Not about relaxing, it's about fixing. If they relax, it's great, but it's about fixing. I want to show you another one. Oh, this was a perfect one. There's a type of deformity called golf tee deformity. I never saw one in my life, but I saw this in certain parts of the world in the Middle East. They're not marrying cousins, but they're marrying within clans. So we see a high degree of genetic abnormalities that we wouldn't normally see. This, I don't even know what to call this. Here's his nose. Look at the shape of his head. I can tell you what's wrong with it by the shape of it. This lambdoidal suture and squamosal suture, and this squamosal suture is what is causing that shape. What's wrong with the kid? Everything in the world. Completely off the charts. This was in Mongolia. Again, my friend Abdullah, another friend of mine, Judy from New York, we treated, I don't know how many kids. It was an endless sea. You can see this is my host's daughter. She's got this flat frontal appearance. It's because her coronal suture is restricted. It's called a brachiocephaly. I want to go back to one more case I'm going to show you, and then I'll be done with this. One I skipped over. Kind of fun story. This boy right here. This picture I'd asked the mom for because I didn't have a picture of him. This was the last time I used a camera that had film, and of course it came out fuzzy. So this metopic suture trigonocephaly, it's nearly gone in this photo. That's the most common plagiocephaly I see. But I want to give you the story about this little boy. The mother brought him in, and he was around, at this age, I think he was around 3 years old, something like that, maybe 2-ish. And he was having hundreds of jolts. A jolt is not a seizure. A seizure has a post-ictal period. A jolt is like you touch an electric socket and your body jumps. And he was having opisthotonus. Opisthotonus is when your erector spinae muscles, you completely arch your back and you have no control over it. If you've ever heard of lockjaw or Clostridium, the reason why you get a tetanus shot is so that you don't get opisthotonus and trismus, which is a locking of your face and your jaw. Anyway, the parents came to me and they said they wanted to know if I could help him with these seizures that he was having, these jolts. And it was scary looking at this kid. And I've treated lots of kids for seizures. And I asked the same question I always ask. Are you seeing anybody else for this? This is serious. She said, yes, we saw a pediatric neurologist at Johns Hopkins. This is one of our premier hospitals in the world. It's in Washington, D.C., about 3 hours from me. I said, well, what did they want to do? They said they demanded to put this kid on medicine to stop brain damage. And I said, well, why are you here? They said they wanted to take the baby from us from child services because we refused the medical treatment. I can tell you in my country, they don't take the baby away from anyone very easily. And when she told me that, it's a big problem for me now. I can't hear that because now I'm mandated to actually report her to the police. So I said, I didn't hear what you said. I'm going to pretend you didn't just say what you said and don't repeat it to me. I'm going to treat the kid. Do not repeat to me what you just said. I don't know that you ran from police. I treated him. I don't know what it was. 1 time, maybe 2 times. It definitely wasn't 3 times. Seizures gone. Seizures gone. Jolts gone. All fine. Metopic suture, all fine. No problem. I forgot all about this little boy. A month later, my receptionist says, there's Dr. So-and-so on the phone for you. I don't know who they are. I don't like talking to people who I don't know who they are. And I said, who is it? They said, it's a pediatric neurologist about this boy, Oliver. Uh-oh. Now I'm thinking I'm in big trouble. I get on the phone and I said, I'm going to stop the share. I get on the phone and I said, hello. And it was a lady and she said, did you treat Oliver Tessar? And I said, Oliver, did I treat Oliver? Of course I know. Of course I know who the kid is. I'm pretending like I don't know. I'm like, I don't know. I think I did. Yeah. How can I help you? What'd you do? I did very light cranial touching, just light. Well, I have a lot of patients I'd like to send to you. You know what? Tell me that when you say hello. Don't scare the hell out of me. So what had happened was I told them, I don't know everything. My license is general medicine. I said, your boy looks fine. I said, you need a neurologist. This is another problem I see in the manual professions. I don't claim to know everything. So I don't know what the newest thing in pediatric neurology is. I know general medicine. I said, your boy was really sick. He's really fine now. I said, no one's going to take your baby away. They don't take a baby away who's normal. I said, find another doctor. That's what they did. They found another doctor. But I'm thinking it's the other one. I'm thinking the police are right behind me. So I stuck my neck out a lot, sometimes to be chopped off, but a lot of what I'm doing, and I guess the take-home point for this, I do a lot of cranial, a lot of visceral, a lot of myofascial, a little bit of everything else. I don't do whacking and cracking. Everyone else in the world can do that. That's good for someone who's really strong and healthy. You wake up, your neck stiff, crack once, done. We're doing that 3 times a week. You don't need me for that. You can get that anywhere. In India, you can get it with a haircut here. The barber will do it. That's for serious. In the Middle East, for $2 in Egypt, they'll cut your hair and break your neck for you. So I don't do that. I know how to do it, but it's not fixing the complicated cases. Most of what I'm doing most of the time really is basic technique. I do other things. I do a lot of energy work, a lot of other strange directions that osteopaths go in. I'm into it, believe me. But if your basics aren't good, nothing else is good. There isn't the secret waiting around the corner. The secret's right in front of you. There's nothing that you don't possess right now to try and help someone to be well. One thing I don't do is I don't go into the spiritual question with the patient, and I don't entertain it with myself. And what I mean is, why do bad things happen to some good people? Why is Junjun sick like that? See, it's not a question I can answer. So I don't try to answer it. It's over my pay grade. You're in the God world for that. My world is, you said, can you do something to try and help? That I have a choice in. If I said yes, I'm all in. 100%. I don't do 99. I hope I see something great. And if I don't, I tried. And if I tried, I don't feel bad. I feel bad about Junjun living his life this way. I don't spend my nights crying about it, nor do I avoid thinking about it. I had a positive interchange with him. He taught me something. I did what I could do for him. I love him. I'm not in love with him. This is a problem. When you're in love with your patients, you're going to feel sad. And you're not going to be as effective. That's the other thing. You are not more effective because you're in love with them. Because you suffer their pains. You're not. You're getting lost. And there's a way not to be lost. That's my story.
Okay. Thank you. You can stop the recording, Matt.
Okay, I'm going to stop the recording.